First off, thanks everyone for dialing in, for joining this call. As I said earlier, so this is the pilot program that we're looking to run, and we are going to be running for NCRS, so that's the National Summary Care Record for Optometry and Dentistry, led by the Primary Care Collaborative. My name's Neville Flanagan. I work for NEXT Consultancy and been supporting the Primary Care Collaborative for just over a year and a half. So welcome everyone. Thanks again so much for your time on a cold, dark Monday evening when I'm sure everyone would rather be Christmas shopping or putting lights up or Christmas trees or something like that. So thanks very much for your attendance. It is very much appreciated. If we can just go to the next slide, Rich, I'll just run through really quickly the agenda. So welcome and introduction. So Mooney, who's one of the GP's medical directors and the co-chair of the Primary Care Collaborative, is going to do a quick introduction as well. We'll run through an overview of the pilot program, where it's come from, what the challenge was, where we're going to, what the pilot program looks like, and then into the main part of the session. Really, we want to try and keep as much time as we can for this so everyone can see the demo of the summary care record from NHS England colleagues. We'll then run through quickly next steps, the expression of interest of those of you that maybe haven't seen it yet or are thinking of completing that. We'll run through that, and then a question and answer. What I will ask is, please use the chat function for questions. We'll try and answer those questions as we go through, unless it's so important and burning that if you can pop your hand up and then answer, one of the team will answer the question. During the demo, like I said, there will be a lot of questions come up. If you can use the chat, we'll answer them. But just so we can keep the floor of that, really, if Rob and the team, if just to hold questions maybe till the end, and you might find some of them are answered anyway. But if we can do that, that would be much appreciated. Okay. So next slide, please, Rich. I'm not going to run through all these names. This is the program team. This is the team that are going to be working on this. Like I said, my name's Neville Flanagan. I've got other colleagues from consultancy as well. But I'll just hand over to Mooney quickly to kind of set the scene and a quick welcome and introduction, and then we'll move on to the pilot background, if that's all right, Mooney.
Yeah, brilliant. Thanks, Nev. And welcome everyone. And what a great turnout at the end of a busy day. So yeah, just set the scene. So the Primary Care Collaborative is a collaborative of primary care providers, which includes pharmacy, optometry, dentistry, and general practice, and we have representation on the Primary Care Collaborative board. And over time, we'll be engaging much more thoroughly with our sort of with the core face and all the providers. We've got plans around engagement, and we work closely with the ICB. As part of the priority setting for all sort of facets of the collaborative, one of the things we were hearing loud and clear was the ongoing issues for optometry and dentistry colleagues to be able to access a summary care record, which can help in patient care and decisions you make, as well as some of the initiatives, whether it's cardiovascular disease finding. It without having access to even the most basic sort of information, like a list of medical problems, medication patients are on, that can be frustrating for colleagues. It can also cause, handoffs in terms of information between general practice and optometry and dentistry. And it seemed that either IG issues or cost issues were just causing blockers. We fortunately, through the NHS England bulletin, heard about our National Care Record team, and Neville and the team at Next have worked tirelessly working with the NHS England team to get us to a pilot status. So it's really exciting. It'll be the first, certainly the first of its kind nationally, unless the NHS England team have got pilots moving more forward. We're sharing this nationally as well. The great piece of work the guys are doing, and thank you for your interest in potentially being pilot sites for this program. And obviously there'll be an evaluation process that the guys will run through, so we understand the benefits it gives providers having that information at hand when it's needed.
Great stuff. Thanks very much, Mooney. If you just go to the next slide, please, Rich. So what I was going to do is really just run through quickly the background and what the challenge was with this. So, as Mooney said, we ran a priority workshop back in May with the collaborative to look at what the priorities were going to be for the coming year, where we wanted to focus attention, and came out loud and clear. Number one was access to patient level information and summary care records across pod. So obviously pharmacy, optometry and dentistry. As pharmacy already had access to the national summary care record, we then set out the challenge, and it's a phrase that I continue to use throughout this program that I hate, but it literally was, and Mooney's laughing already. It was what's the art of the possible? Where can we even get to this? What could we even aim towards? And expect very little, to be perfectly honest. So we set that out. We said, okay, we'll do a scope and phase to actually look at, is it even possible to get optometry and dentistry set up so they can view some kind of summary care record? The purpose of it really was around patient benefits to practices, but again, understanding what the needs are for pod providers, identifying what those challenges were, and we laid out an options appraisal with various different options and various different ways that we could potentially look at this. So again, the scope around this was really identifying what the needs were, but what the challenges were across primary care. And often the want, the ask is different to the need. So we explored all of the potential benefits of this. And as I said, patients to benefits ultimately, but also business. And a lot of that admin burden that is felt through optometry and dentistry and general practice for things such as, obviously, we need to make a referral. Hey, we need to view this information, what medicine, what medication is the patient on, etc., etc. We also wanted to understand any of the concerns. So that was concerns from general practice, whether that be safeguarding, whether that be information as well, any concerns that other colleagues might have had. And we consulted with LMC colleagues, LOC, LDC, to really understand fully what we were really getting ourselves into almost. We did look at, and we're continuing to work closely with the GNCR. So anyone knows that the Great North Care Record, and that still sits as one of our longer term ambitions and goals, aligned with NENC ICB, in terms of where this can go to and where we can get to with this as well. We then formed a full report back to the collaborative, and we put in there the recommendations after, well, obviously we'd spoken with NHS England as well, that actually we could set out to run a pilot with optometry and dentistry for up to 10 practices, just to see what the ambition was out there to do this, with then a plan to potentially roll this out at scale further. And lo and behold, we're here. So as Mooney said, this was really kind of a pipe dream of could we even do it? And lo and behold, like I said, we're actually here. If you get the next slide, please, Rich. So that's the background. That was the scoping. That took us about 3 months of semi-structured interviews with all of the primary care collaborative providers, and formed this timeline. This, if you like, this plan for how we could do this and how we're going to do this. So again, working with NHSE colleagues that are on the call tonight as well, we agreed we could have 5 optometry and 5 dentistry practices. That was because Stephanie and Simon were absolutely keen that they wanted this to work. So we said, okay, let's go for 10 and again see how that goes. We'll provide support for those 10 as we go on board. So again, we've got the expression of interest that's out at the moment, and we'll come on to that later on. But in November, it was really a case of scoping all of this out, developing the guidance, how we would do this, how it would work, what it would look like. We're into December now, confirming obviously who the practices are going to be that we can do, that we can go through this with, agreeing all of that governance, putting that toolkit together, and really starting to kick off the training. Then as we move through to January and February, we'll be going live with the practices that have been nominated for the pilot to review through in March, and then ideally we'll be pulling this in with all the results within a 3-month phase of go live to review, look at what the impact is, the effectiveness, evaluate that, adjust where we need to, see how it's really worked, and then look to see if we can take this forward as a pilot later on, which would actually open up much wider. So that the scope is there really to roll this out potentially with ICB buy-in to get this out potentially across NENC. And as Mooney said, it's the first in the country that we've got this far, and actually we're looking to do this. So I've kind of, that's a real whistle stop, but that leads us now on to I guess the demo. What I will do, I'll just say, I don't know, I did see a question pop in the chat there. I don't know if people have got any questions around the pilot, what came before the scoping exercise before we go into the demo. But I'm just really keen that we do get into that demo and give obviously Rob and the team plenty of time. Okay, so GNCR, NCRS. So I don't know, Rob, if you want to pick this up, but the GNCR is the obviously the Great North Care Record. That's actually funded at the moment through some of the foundation trusts and the ICB. They share data across with themselves. When we approached them, they did say this is in the hard to do pile for us, and actually it is in their roadmap. It is further down the line, but they are really interested to see how they can share data, and data can be accessed within primary care, but they're just not there yet. We can put a link in for the GNCR website if it would be useful. And obviously you can have a look at that. The difference then, Rob, I'm probably going to come to you in terms of the difference between GNCR and NCRS, but that's a perfect segue for me to hand over to you as well, if that's all right.
That's absolutely fine, Nev, not a problem. Good evening, everyone. Rob Jordan, Senior Service Manager, NHSE, long time implementer of the summary care record. Can you hear me okay? See me okay? Good stuff. A few nods. So to come back to the question then, at the top level, I would say detail. So your GNCR, your Great North Care Record, will be warts and all, birth to death, detail, longitudinal, whereas the NCRS is predominantly GP record creating the summary care record and a number of national flags, which I'll demonstrate later, alongside that. So it's not the depth of the record, it's simply a high-level summary of what's available at a peak, hence the name. Does that help for now? Yeah. Okay, cool. Right. Quick demo then. Would you see that all right? Good stuff. So I will start on the website. So if you Google NCRS or National Care Record Service, you will land here. This is the homepage. This includes all the things that are in the NCRS, starting with demographics. I will go through the most of these today, but generally what I'm saying is upon your onboarding journey, we will either direct you to here or we will kind of give you the link. If you ever are at a terminal and you have access and you don't, for whatever reason, have the shortcut, there's a nationally available shortcut under this big green box here, and you hit it and it will load up your authentication method. Okay, some of you, a few of you may have smart cards already, but I think for this pilot we're going to be using the Authenticator app. This is obviously a simple authenticator on a phone of your choosing. You then register your digital identity. Zam and team will be sorting all that out. I am simply logging on with my credentials here. Once that logs in, that provides me with an authentication kind of request to my app. I then go to the app, put in the 4-digit PIN once I've unlocked my phone, and hopefully, fingers crossed, I am in. Okay, hopefully that's making sense so far. So I've got multiple roles. Some of the roles don't allow me access to NCRS, but allow me access to other things. Okay, some are test. But for today, we're just going to use the NHS England kind of support one. This actually does allow us to do a lot of things, but not all the things I'm going to demonstrate today. Okay, so simply click. That will then confirm that's the one I want to use for today. And if you really want to know, this is all the things it allows me to do. Okay, very rarely do we use that, but it's useful to know you've got a visualization of what you're allowed to do. Okay, and here's really how you start the journey. So this is the yellow pages of patient search, really. If you don't have an NHS number, there are various other ways to search. There is a business, a basic way in, gender, last name, date of birth, pretty straightforward. There is an advanced trace if you, for whatever reason, have got a different a date of birth and you need to kind of do a range gap, specific gap on that. And there is a postcode search, but that's quite niche functionality and added on extra. So if we do hit an issue there as part of the pilot, we might look to do that later on. Just for ease of use, I am going to just drag a test patient, so completely synthetic data, into this record here. For some reason, it doesn't like that. And here we go. There you go. Okay, as you wait for it to load, this is the kind of patient home screen. Okay, this patient is not the one I wanted to use, but this is the patient that's got almost everything you could possibly have on a patient. Okay, so for the pilot, generally you will see this option and this option here. Reasonable adjustments are a relatively new thing, which I'll demonstrate in a second. Okay, the other yellow banners are obviously quite self-explanatory, and we'll come on to them later down the road. If you are interested in any specific patient demographic related information, so just to confirm the patient's identity, for example, there are a number of things at the top you can use for that. But if you really do want to deep dive into, let's say you needed to know their GP practice, for example, okay, you can jump into here. And obviously this is a test patient, but there are various informations on here. The GP and care provider tab obviously provides the information that you need. On the left-hand side, this is the patient's registered practice. Currently registered practice with any GPs that are registered at that site. Okay, if they did have a nominated pharmacy or appliance contractor, for example, there'd be things listed at the bottom of this screen. Next of kin is often held, but maybe not held for everyone. So you'll get a lot of the mother baby records, and you'll get a lot of more elderly patients with obviously next of kin held there. It's not for everybody, but it is available and it is a useful piece of functionality. Flags and alerts. So this is obviously depending on your access rights. I've got quite high level access rights here. So this is most of the flags that are available. The one you'll see the most on patients probably coming in and around your services will be the reasonable adjustment flag. And that is simply a flag about reasonable adjustments, underlying conditions, and any things you need to do to kind of work their care up in a better way. Very new piece of functionality, but available nonetheless. Hearing loop, hearing, all the things under the reasonable adjustment piece in the Care Act recently. The piece we're really interested in today is under the clinical piece. So the clinical tab here. So the summary care record. Now, for those who have heard of the summary care record before, there are two types of summary care record. There are a summary care record, which is just the standard one, which we refer to as core summary care record. So that's allergies and medications. And then there is the additional information summary care record. The vast majority of the population have got this one that's nominated on this patient here. So this is the patient with additional information. So what that means is there's a summary of their healthcare after their discontinued medication. So for every patient practically, unless they've opted out, and if they have opted out, this won't be available. It will simply say the summary care record is not available for this patient. There will be allergies, adverse reactions, acutes, repeats, and discontinued medications for every patient, obviously, if they're on them. Additional information only comes in when they've got it, but we're in about 88 point something % of the population who have got additional information. So in the most part, you will see a summary of their entire kind of GP record within reason. What that looks like is hidden behind this question. So because we are a slightly old version of the sharing arrangements, we still stand by this question. So we call this PTV for short, but this is our permission to view question. And given that this patient might not be known to you, it's quite a useful question to put in here. Okay, this is what lists and tracks all the audit and generates all the alerts. But in essence, if the patient doesn't give permission, there is another option that isn't visible on this screen, but it's a little red box that's on this side, which I don't think you guys will see in the care settings that you're kind of delivering care in. There is a kind of an A&E smash the glass emergency access button here. I haven't demoed it today simply because I didn't think you need it, but that's obviously another option. If you really did want to put in a reason, you can do this completely voluntary, however, does support and does help the privacy officer that sees any of the alerting that comes out the back end. Okay, I've also got high level access here for other reasons, so court orders, that type of thing. where we do things for missing persons things and that type of thing. You won't have that. So I'm just going to put test in here just for means of today. My keyboard wants to work. Okay, and then we're going to click on yes. So within a couple of seconds, you will get the summary care record loading up. Okay, this might look slightly different to what you were expecting, but every element is headed. So we call these CRE headings or care record element headers. And generally anything after the discontinued medication, as I said before, is what we call additional information. Okay, so vast majority of the population have got everything up to that kind of yellow box that I highlighted there. But historically, pre-COVID, the vast majority of SCRs only contained those headings. After COVID, we did a lot of work and obviously expanded it to do the COVID response. And we've now included all this as 88% of the population, give or take a percent. Okay, so first thing to note here when you're looking at a summary care record is this date. Okay, so if you remember anything from this presentation today, it's kind of you need to clock the time and date the SCR was created. Okay, like I said before, this isn't the patient I wanted to pick, but actually it does show a number of things that are quite helpful to show in a demo. That time and date is on every summary care record, and that is the line in the sand where the last summary care record was sent up by the practice. So generally, that's the last interaction their registered practice, the patient's registered practice has had with that patient. That could be a member of staff opening and closing the record when adding a medication, reauthorizing the medication, adding an allergy. Could be a consultation that involved one of those headings, or at least information under one of those headings, which then once that record was saved, the script was printed or sent on EPS, or that record was simply just saved and something was pertinent to that history of the patient, it then got kind of sent up to spine. Okay, so this one's nearly a year old, let's say 12 months, 11 months old. So I would say this patient's probably not on any regular medication, just given that date. If they were, obviously that would be generally every 4 to 6 weeks. Okay. You will see, and I didn't really want to demo this today, but you've got it anyway, which is quite helpful. This patient has actually finished their registration at that practice, so they're in limbo, so they're about to move to a new practice and haven't yet registered at their new practice. So this SCR is actually just stagnant. It just sits there waiting for the next practice to be picked up. This patient's journey might have been, they might have gone abroad working or something like that. I don't quite know, but that's just helpful to see, because that is one of our many requirements that are mandated by all the GP systems to make sure that SCR, if it's not regularly updated, and there's a reason why it's not regularly updated, to stick it right at the top. Okay, I'm sure there'll be some questions on that, so I'll come to it slightly later. But let me walk through the SCR for now. There is a search here. You can search for specific things. Obviously, you've all got your specific areas. So if there was something the patient was telling you while you were doing kind of that, clicking that patient in, if it's vision related, ear related, eye related, teeth, tooth related, dental related, you could type it in here. I've no idea what's on this patient record. There's one entry for leg. So there's something in there that's got leg either in the word or there's something wrong with the leg. They're unlikely to be anything to do with teeth. There might be something to do with ears. And it will highlight that as we go through the record. Okay, so it stands out. Useful in some scenarios, not useful in others. Generally, you don't know the patient, so you probably want to just skim the record just to give it an eyeball and actually understand the patient as a whole rather than just nitpicking. So let's start then. Let's walk down the SCR. So allergies and adverse reactions. So these can be substance related. These can be, i.e. Allergic to a specific substance, which is SNOMED coded, or it could be a specific dog dander, general allergies, whether it's hay fever, that type of thing. So substances or drug related. There may be some spurious things in there. Non-otherwise specified allergy, and then in this, which is unfortunate for this allergy, this is free text, so anything with a little blue stripe here is supporting free text that's been added in by a human. So generally that might be grass pollen for that exact, sorry, if it was a hay fever, it might say something like grass pollen, or every other year, or that type of thing. It could be Any length, I think there's a 5,000 character limit in most systems on that bit. You very rarely see more than one line. And in some systems, you see these examples are actually blank. In some systems, they might have challenged those allergies. So you can be either certain or not very certain, depending on whether that's been challenged, tested or not. Okay. Moving down, so we do have parameters for these first few sections. So acute medications, as you can probably gather, it's an acute script, generally very short term, maximum of a month generally, and it's usually reissued. But we run a whole total of a 12-month period from the last update of that SCR. So that obviously the date was the 11th of Jan. This rolls back 12 months for that date. It will give you the prescribed date, so the date of issue. It won't tell you when they picked it up from the pharmacy, but it will tell you the dosage instructions and if there were any specific dosing instructions or free text above and beyond what is on this example, as you'll see on the current one. There might be a little blue stripe and some supporting text about how to take that medication, a note for the patient, can't order before a certain date, that type of thing. And don't take with certain foods, you know, interaction type warnings and things. So slightly moving down then, acute meds finished, current meds, so that's obviously things on the patient's B side, so regular medications. This can be as long or as short as the patient's underlying record. We have seen obviously quite significant amounts of medications for frail elderly patients. We're talking a couple of scrolls on here. All above board, all absolutely, you know, what that patient's on. It just might take you a while just to get your head around the formatting of quite a long table and obviously everything looking very similar. If you are looking for a certain medication, I'm sure your eye will draw straight to it. Discontinue medication. This is quite helpful because you do get a reason for discontinuation. Okay, so I don't want to confuse things by the kind of number of authorized or anything. You'll get the gist of that, but in essence this medication was dispensed as a 6, so the patient can have 6 have been dispensed, 1 can be dispensed every 30 days by the looks of this, and then they go and pick it up. Okay, it's been discontinued because the patient's been deducted, so the patient actually left the practice, so that's why it's been lost. So the data transfers to the new practice when that patient registered. It just doesn't obviously give a clinical reason, you know, the patient wasn't allergic to it, etc., etc. That's generally what you see here. Okay, this is where the good stuff comes now. So after your medications, you get the kind of whole birth to death kind of window, I suppose, of the record here. So problems and issues is not the first heading in our list of care record elements, but it's generally the first one you'll see for the vast majority of patients. So we do have 2 higher priority headings before that, which not a lot of patients have, and that's risk to staff and risk to the patient. So when patients have had, let's say, coded in their records some sort of self-harm, or they have been, you know, some sort of violent indication of in previous healthcare settings, and that's been coded, certain headings obviously lift those headings higher up the SCR. So this patient doesn't have any, and if that heading is empty, then it doesn't display. Okay. Problems and issues, like I said, generally the first heading that you see. This patient's got very few. If you had a diagnosis of asthma, you would generally see it under a problem heading, obviously, because it's episodic. At least your treatment's episodic on top of it. All right. Other things that you might see here could have been manually kind of bumped up the record by the clinicians at the patient's practice. So let's say something like, I don't know, some sort of like a knee, we'll take that knee pain there. So some sort of, let's say a runner's knee or something, you know, band issues or something. So they're struggling to walk or they're struggling with mobility. That could have been kind of lifted up the record to kind of almost put a sticky note on it to say it's now become a problem or it's now an issue for the patient. Here's the information about it. And generally you get a little bit of free text, which is kind of driven from the record. Okay, so moving down, clinical obs and findings, it really does what it says on the tin. Generally, when you've got things like this, this won't be a test patient's record like this. It will be more free text, okay, and it will be we've had this, you know, 12-month review. We've spoken about asthma, you know, inhaler kind of technique and all that type of stuff, depending on the conditions, obviously. You will see some repeat codes, but that's generally just down to the data kind of modeling. A clinical finding, obviously, on pain is pain, so it appears in under 2 headings. Okay. So skipping on down, treatments, again, quite self-explanatory. You'll generally see some sort of immunizations, vaccinations, or any secondary care treatments per se that have been then added in by the practice or kind of scooped up by the practice as part of a discharge note. Okay. Investigation results. You won't see blood tests. You might see notifications of certain parameters within blood tests, but you won't see regular blood tests here because we don't want the record to be absolutely massive. Okay. Care events, so specific reviews, specific, like annual kind of diabetic foot check, that type of stuff you will see here. Personal preferences, so we're getting quite lower down the SCR now. So this is kind of DNA CPR, Gillick competence. Any preferences? I would like my mail to go to my next of kin kind of thing, and anything around that kind of ilk. As we move further down, we've got other things about specific GP kind of admin. Some codes you see regularly, some codes you see don't. This nominator thing came in a couple of years ago, and every SCR seems to have it now because it got added by the kind of practice GPES kind of area. Care professional notification. So this is not the document itself, okay, but the kind of information and data around a referral, an onward referral, or a referral to an MDT, or that kind of response to something. And often if it is a waiting, on wait list or whatever, you will see a bit of free text where that blue stripe is, just to indicate that. Okay. Patient correspondence, obviously quite self-explanatory, and social personal circumstances. So this is domestic and generally language communication preferences. So you'll see, main spoken language X, because it's asked at a new patient medical. You'll also see things like homebound, lives with, that type of thing. Here you often see next of kin, daughter, name, mobile phone number, kind of to link it all together. It might be the same person that was in the PDS screen that I showed you earlier with next of kin and contacts. It might not be, so just be wary of that. Okay. And then you get the sent date. So the creator date at the top and the sent date are generally the same. There might be a couple of minutes within it, depending on whether it was sat in a purge queue or not at the GP practice. And kind of that is the end of an SCR per se. If you did want to print it, there is an integrated print view here, so you can print the entire SCR or just the allergy meds, and that will automatically force it to a PDF view with the patient's NHS number, the name, the time, date, and it will kind of print a PDF and allow you to take that out and kind of import it, attach it to another medical record if that is what you want to do locally. Some people do that, some people don't. Some people print it and annotate it in A&E. Completely depends on how you want to kind of engage with it. Reading it on screen is completely fine as well. Okay. Should I stop there for SCR questions?
I've just checked. There's nothing else in the chat, Rob.
Okay.
So unless anyone's got any questions and they want to just pop their hand up now. Oh, Stephanie.
Hiya, good evening.
Hi there.
Rob, I think it's probably self-explanatory, but I'll just double check. On the left hand of my screen, it says summary care record in the blue, and then it's got blue words underneath, which are the headings that you've run through. Can you just click on a heading and it takes you to the part that you want? Right.
Hyperlink.
So you haven't got to scroll through it all the way through.
You don't have to scroll through it at all, and that's there for when you're on a desktop. So hopefully this is demonstratable, but we've made this software very mobile responsive. So if you shrink it, I don't know how much of this screen you can actually see, but if you shrink this enough, that actually disappears. And then you get a drop down. I don't know if you can see that. Can anybody see that? Sorry, I can't hear you. I'll see you.
You can see that.
Yeah,
sorry, we're all
so that sorry, I was just demonstrating on an iPad. that's how the paramedics would see it. So they'll turn their tablet or their iPad portrait, and they'll use it like that. But obviously on a desktop, we've got more real estate, so it opens up. Okay.
And the other thing that we talked about is if you log in the morning, you can, obviously you've got to log out the actual patient, but you can leave it open on the background in the computer to come back to it easily. So you haven't got to keep logging in and out.
So so there is a timeout. So if you don't play with this browser window for 30 minutes, it will stop. Okay, it will lock. Okay, but then it's very easy to log straight back in. Okay.
Excellent. Yeah.
While I'm here, we have fairly recently added this section in, which tells you all the new things that are coming, and this will highlight anything that's kind of feature in the latest drop. So this is really quite long at the minute, and you can upscale the things. This is humongous with the amount of stuff on it, but obviously you'll only get shown the stuff that's brand spanking new in a little trumpet icon when it's there. So we are iteratively changing it, and I think, to be honest, the screen after the patient, I think this screen has actually changed ever since we last demoed to you guys.
I think it has, yeah.
This cyan bar here, we've squashed all the white space and allowed the screen to be a little bit more manipulated, and we've added a few more of these in as well. So this is copy and paste. So a few people are getting a bit miffed with how it did what it was doing with me from that email with that NHS number. So we've actually made it a little bit easier for people to bring out and copy through to different systems. Okay.
Brilliant.
Great stuff. Happy to say any wider questions as well, given this patient's got practically everything on it.
I was just going to go back to that original question because I reread it again and realized actually one of the other key differences with this is this is national. Obviously, the Great North Care Record is only the Northeast, so it's only the Northeast providers that are signed up. So if a patient were to come out of area, obviously, if someone from, say, Cornwall travelled up to the Northeast and needed an appointment, actually you wouldn't be able to see their records in the GNCR because obviously it's not a national summary care record, it's only local to the Northeast. So just wanted to flag that as well as one of the key differences.
Yeah, and a lived example of this is my wife's a type 1 diabetic. She, for whatever reason, forgot her insulin that was in the top of the fridge when we were going to the lakes for a couple of weeks, a couple of summers ago. She realised when we were halfway across the A66, and we got there, and I said, "No problem, we'll just go to Boots in Windermere." And she said, "What do you mean?" And I said, "Well, we can just go in Boots in Windermere because there's a Boots, and they do SCR, and they will look at your record and see that that's the insulin that you're on, and they'll provide you with an emergency supply because you're a tourist." She kind of looked at me like I was an alien. Anyway, that's what happened, and that's what ended up happening. And she got her meds, and it was an emergency supply. Everyone's a winner. So it does work, and all they did is log in and obviously looked at the SCR, worked out who she was, GP, reason, everything. Yeah, everything went through.
Question coming there around letters.
Super useful.
So at the moment, I know letters aren't, but I don't know if you want to cover that, Rob, in terms of plans and future plans.
Sharing. Yeah, so if you when you say letters, do you mean correspondence from secondary care, or do you mean kind of care planny type letters? Do you mean letters as a document type, or do you mean whose question?
I think it probably means the letters that from ophthalmology, because in optometry that's our big bugbear, is that we don't get access to the letters that are feedback from our referrals going in. So I can answer this for the purposes of this at the moment. No, ophthalmology letters are not visible, partly because they're not. It depends on what the GPs have uploaded, but the actual episode of care, as long as the GP has been told that the patient's been at ophthalmology, that will be uploaded, but we're not going to see the actual letters. Potentially with the Great North Care Record that might be possible, but that is further down the line, and we have to prove there's a need, because apparently the Great North Care Record people don't think we need it.
Yeah, and when we first did the scoping of this, probably should have said right at the beginning as well, there were 4 key areas that we were asked if we could, again, possibly get access to. That was medication, allergies, and so medication, medical conditions, allergies, and letters. Obviously, where we are at the moment is 3 out of the 4, but as Rob's already demonstrated, there's 3 out of the 4, but a whole load of other important information as well. So I guess, yeah, it's a bit of a bully's special prize with the letters, but unfortunately, that's a national thing that obviously I know the guys are working hard to do, but at the moment they're not visible. There's a couple of other questions in there, Rob. I don't know if you've got access to the. So will we be able to make changes to the record, i.e., record next of kin or power of attorney?
Okay, so on the next of kin piece, on the when I showed you the demographics right at the beginning, that piece will be completely editable. Yes, the SCR, the document itself, the kind of one with the hyperlinks on the left hand side, no, you can't touch that. That's a GP only send. Hopefully that's all right. There was something. Oh, sorry, power of attorney. If power of attorney is recorded at the GP practice, it is one of the member codes of our inclusion data set. So that will be sucked up and it will be in the personal preferences care setting in the summary care record. So if you do ever need that, it's likely to already be there. I'm not saying it will always be there, but we have seen it on a heck of a lot of SCRs for that kind of age population.
We discussed this as well when we talked about ahead of the pilot, so just jumping in again. So one suggestion might be, if we find that there's things that either dentistry or optometry think are definitely missing, and we won't know this until we've actually started using it, then we'll want to take that back as kind of feedback about what you're thinking. And there might be the potential for us to do a little form that you can then send to the GP going, we've been using the share care record as a pilot and this bit's missing, can you add it or whatever, just at least for as a temporary measure for the minute. I know that's not ideal, but we don't know exactly, because we're only seeing test patients. Until we've actually been seeing some live patients, it's difficult to know whether we actually think things are missing or whether actually everything we need is there.
Yeah, and it's just to come back on the letters thing, it's fair to say on the right-hand side, you will have seen the kind of demographics piece, the clinical piece, and then there's a documents panel. There might be a fourth one. We might kind of rejig that home screen of that patient, but we have got functionality called record locator, so national record locator, which has the ability to carry documents, care plans from secondary care at the minute. There are more and more types of documents being uploaded to that space. And we are also doing something in the background with some GP Connect data, which carries the more useful kind of fire-related attributes, which we will then bring into NCRS. So what we're saying is, you guys are just getting in the door. We're going to add all, and apologies for the term bells and whistles there from last time, but there are more and more little tidbits coming, which you will either have or have later.
Yeah, is it Shiv? Do you want to come in there?
Yeah. Thanks very much. Just 2 quick points from the dental perspective. For dentists, I think the most important win here would be for us to be able to see what medications patients are on when they turn up, because a lot of the time they turn up, especially urgent patients, and sometimes with carers, and then you spend ages ringing the doctor to try and text you or email you the meds. So that would be really handy. And the other point to make is we don't generally refer to GPs. Obviously, our referrals mainly go to the dental hospital to a consultant. And part of the problem there is it disappears into the ether. And sometimes we don't get a response from the dental hospital, but they always copy the letter, the response to the doctor. So it would be quite useful if these letters were all in one place and we could access the SCR and see the response. Because sometimes we've got to chase it up and they might have sent it, it's got lost somewhere. But if they copy the doctor, the GP's practice in, and we have a place where we can just upload or see all the letters, for that patient, that'd be really useful. Thank you.
So happy to come in on that. So the GP Connect stuff that I was just talking about, so that's the stuff we're working on in the back door that's not currently there yet. We'll definitely offer that, Shiv, because that's the kind of third layer of the onion deep, really. It's the stuff coming the other way that we can't see because our stuff's getting pushed up. But it's in the record. It's just we don't look at it because it's not that summary level. So yeah, definitely it's on the cards. It's just how often
Which is really the point of this pilot, isn't it?
Yeah.
So we're really excited that it sounds like dentistry have really similar concerns to optometry for slightly different reasons, but we're both working with secondary care departments that don't communicate directly with us, and it's makes life more challenging than it ought to be. So this is a beginning, but hopefully the learning from this will help to shape something else, but we don't know exactly where that will go yet.
Absolutely, and this is what we were saying earlier. So look, when we set off back in May, we hoped and dreamed we might be somewhere near this, to be honest, Shiv. And the fact we're even having the conversation, the fact you're asking these questions, the point of when we go live, and from February, March, April, and then onwards, for those kind of 3 months that we evaluate this, we look at that, we look to see what we're learning from it. If you don't get everything from it, it might be actually you use it 1 or 2 times, but those 1 or 2 times might be really important that you actually view that information. Like you say, if it's an elderly patient or someone comes in, or actually you might find that you're not using it at all. And when we had an earlier run through with this, that's one of the things Rob was saying. Sometimes people will go for weeks and not use it. You might actually find that you'll be using it all the time, and you start to ask more and more of these questions. Actually, can we see this? Can we see that? Because that would be more beneficial. We don't know what we don't know at the moment, and that's what we're going to hopefully learn at the end of this pilot.
Yeah, I mean, if I could just add, I think for us, I think from dentistry, we've really been asking for this for years. And, you know, it's been a big bugbear of ours. So I think it's a fantastic opportunity to try and make something out of this, even on a national level, you know, and you know, the current administration has said we want to go from analog to digital, and we're still way behind in terms of communication. So it's the right time to push the buttons, because that's where the resources are.
It's really good to hear. Yeah, and thank you for that. Just conscious of time, are there any more questions in terms of the demo, or we'll move on to the next steps and the kind of the EOI, which I think Rich is going to lead us through. But unless there are, I think Adam's responded on your behalf as well, Rob, on a couple of other questions, so that's brilliant as well. All right. I just want to say thanks very much for that, Rob. Really informative as always. And like you say, it is constantly changing as well. Every time we see it, there's the little bits on there. But no, that's really great. Thank you. Right, Rich.
Yeah, thanks, Nev. Hi, everyone. My name's Rich, providing some PMO support on this pilot. So I guess just hopefully everyone found that beneficial going through the demo, seeing kind of what you're going to be able to access and how to navigate through it. In terms of next steps for if you're wanting to participate in the pilot, we need you to complete the expressions of interest form. I think we've got pretty good responses so far, with quite a lot coming through already. The deadline for that submission will be 12 o'clock this Wednesday. After which we'll close the form and start reviewing kind of and selecting the 10 pilot sites. There's the contact details for Simon, Stephanie, and then the guys from Next, so myself, Nev, and Michael, if you've got any questions kind of in the next couple of days. But yeah, apart from that, has anyone got any questions regarding the EOI? Steph?
Yeah, just because I know there was at least one optometry interested party, and I think there might be a dentistry one who aren't on tonight. So is the recording going to be available ASAP? So we can get this out?
I'll send it out to everyone as soon as possible.
Right. And then how, if we're only going for 10 sites, how is that going to be narrowed down if we ended up with 25 interested people?
If we have 25, Steph, I'll do cartwheels down the road, to be fair. And that can be minuted. No. So what we'll do, the plan was that we would have 10, and that was a manageable amount that we felt we could manage, guide through. And obviously it's only a short space of time to get these practices up and running. The expression of interest will go through with yourself and Simon in terms of optometry and dentistry leads to identify the key practices. If we end up with 12 or 13, we'll just need to have that conversation to say, actually, could we run this with a couple more, with a few more? We actually, in terms of the registration authority, and Zam and the team are on, and Matt's on the call, we do have a license for a few more, but we would just have to gauge that on the level of interest, the level of kind of digital maturity, if you like, of the practices that want to or interested in the pilot. And we'd have to just agree that with yourselves, because obviously you're leading on it from an optometry perspective, Simon's leading on it from a dentistry. If you pick 20 each, I don't know if we could really manage that, but like I say, if it's one or two more, let's have that conversation. And like you say, we'll be with Rob and the team, because it's all the work that we need to do in the background in terms of that training, the support to get people up and running, the support to get live. I guess we didn't want to set the bar too high and achieve very little. So we'd rather achieve full access and get 10 people on board, on time, on track, running with it, than try and take too big a bite. Hopefully that makes sense. Go on, Stephanie.
No, it does, but I've just going on the training. Obviously there is a mini training module. I haven't done it yet, but I know Simon has, so maybe it'd be interesting to find out how long it took him to do.
Yeah. It took me 45 minutes, Stephanie. It's quite quick and easy. You go via the Learning Hub. Now, for dentistry, a lot of us will already be registered with eLearning for Health. And when I attempted to register with the Learning Hub, it said you already have an account. I tried my eLearning for Health login. That got me straight in. I tried going in the other way just to see via eLearning for Health, but I couldn't find the module. So if you go in via Learning Hub, if you either create an account, or if, as I say, a lot of people in dentistry will already have an account, you log on. It takes about 45 minutes. There's a test at the end, 10 questions. You have to score 80%. I do caution that a few of the responses were not covered in the presentation. So if you say, how do I pass? My little tip is, I got 9 out of 10, so I passed. I couldn't work out what had gone wrong. So you can actually review your answers, and it'll actually tell you what the correct answers are. So I possibly shouldn't tell you that, but there's probably, if you do not pass the first time, you'll pass the second time. It's quite quick, it's quite easy, and it's not too onerous at all. I think the only thing that I would possibly add here, which I'd sort of made a couple of notes for my dental colleagues, are that if you were selected for the pilot, you have to have completed the Data Security Protection Toolkit, which is already a contractual obligation for dentistry. You'll need your practice ODS code, which I remember saying when we first discussed this, what's that? It's your code, your site code on Compass. So my old wide open one was V03355. You can find that on Compass. You have to appoint a privacy officer, which is slightly different to your Collicott guardian, but I would suggest it may be appropriate to use the same person. And that's the privacy officer gets alerts for the purpose of audit when people view the SCR. Oh yes, the training, sorry, also mentions a smart card quite a lot, but we've already covered on this presentation that we're going to be doing the multi-factor authentication via your registered personal device. Hopefully that sort of
No, that's great,
extra.
and
Yeah.
that's getting into the next steps as well, Simon. Absolutely. We do have a whole load of slides that we will walk through with the selected pilot sites as well in terms of next steps. So the ODS code, the training that you need to go through, how you set up the multi-factor authentication, all the self-assessment, all of that. We didn't want to overload this slide deck and this information with too much. But that will come next once obviously we've got the interest from the practices. Absolutely. Sorry, Rob, go on.
I was just going to come in on Simon's first question about why you couldn't get in on e-learning for healthcare. Simon, it's an interesting answer. Me and Adam weren't allowed to build anything on the e-learning for healthcare platform because they were moving to the hub. So the hub's the latest, and that's why I think your username and password words across. So that's the future.
I always sort of, when I'm looking at anything, I think, okay, I'm going to get this question for someone. Why can't I get it on e-learning for health when it is my login? So I've got some notes here. Don't use that. Use your login, e-learning for health login, but use the Learning Hub address, and that gets you in no problem.
Absolutely. And just to touch on the point about the smart card piece, me and Adam already had an action to review the e-learning. We will do that and we will tweak it, make it a bit more robust. Linking back to what we were saying before, why now? Nev and the guys got in touch quite at a good time. They were pushing on an open door. The NCRS wasn't web-based at the time we built the e-learning, so smart cards were the only way in. So we've come leaps and bounds. A lot of people are kind of doing what Nev's team were doing 6 months ago, kind of jumping on board and going, actually, everything's really quite easy to get on. No installs, everything's web-based, that type of stuff. So you're the first to the party, really, in a big way. So, good on you for that. And it sounds like it's going to go pretty well.
Excellent. Thanks for that. Just on the questions, I've just seen Andrew's question around compensation for time participating in the pilot. That there is no funding for this. This piece of work is actually funded through money that we've been given through the ICB in terms of their funds for the Primary Care Collaborative. So the collaborative themselves are paying for the time for the program team to actually run this. I think in terms of the compensation for the time, there will be no financial compensation for that. Hopefully what we will find is it's more the benefits outweigh in terms of your practice and how you can work, that you'll actually find that. So it's not a monetary value that you'll be compensated. Hopefully, I guess the compensation is it'll save you a lot of time in some of the examples we've already been given, and actually in your practice, how you'd be able to access this. But no, there's no kind of monetary compensation for that. Sorry. Okay, I know, Rich, sorry, that was your slide. So in terms of expressions of interest, if you haven't already done it, the information there, Rich has put it in the chat as well. I think unless there was anything else on there, Rich, that you wanted to run through, we're pretty much nearly bang on time. Excellent. Just to close, again, thank you so much for everyone that's dialed in. I hope you found it useful. We'll share the slides. We'll share the recording as soon as we can. If you're interested, the contact details are all in the slide deck as well. Just reach out to Rich, myself, or Michael, or anyone in the team. But I hope you have a lovely evening. Thanks again so much, and look forward to getting this pilot off the ground, up and running. And hopefully in 3 months' time, who knows, we'll have a full program to take back the ICB and say, why would you not commission this? I'd just like to say thanks to all the speakers, all the presenters, all the people that are on here as well that didn't get to speak but are here, in case there were any tricky questions that I couldn't answer, or any of the other speakers. So thanks very much. But yeah, I'm going to leave it there. Thanks very much all. Have a good evening and take care.